Great. So should I get started or should I wait? You let me know.
Could we maybe wait 1 or 2 more minutes and then get started?
Yes, we can. So where are you guys? Where am I talking? Where is everybody?
So we're kind of all over the world, but I'm currently in New York. And if everybody else wants to mute and say where they're from or type it in the chat, that's also good.
Okay.
Hi, I'm Robin Zhao. I'm currently in Westwood, so I'm a UCLA undergrad, so I'm like
Oh my God.
Hospital. Yeah.
That's really far. Yeah. Okay. Well, nice to see you. And Abigail, where are you from?
Yeah, also New York.
New York?
Yeah.
And Erica is frozen. She has her photo, so I don't know if Erica's there, but anyway. Well, nice to see everybody. I'll keep this pretty interactive and low key. Are you guys undergrads or like just so I know?
We're a mix of high school and college students.
Okay. So no med students really yet.
Yeah, I don't think so.
Okay, just so I know, because I've done a few of these for high schools and middle schools and college and pre-meds and first year med students. So I'll just, keep it pretty open. Well, thanks for all being here. I hope it'll be fun. And yeah, who organized it? Was it you, Michelle, who started this?
No, Abigail and I started it.
Both of you. Okay, great. Okay. Sorry, let me turn off my phone. Cool. And it looks like you have a lot of followers on Instagram.
Yeah.
That's impressive.
So if you want, you can start now. So it's totally
okay. Thank you all for being here today. My name is Dr. Nina Shapiro. I am a pediatric otolaryngologist or ear, nose, and throat surgeon at UCLA. I've been there for a little over 20 years. And what I'm going to do today is I'm going to talk about sort of how one gets to that specialty, should one choose. And then we'll talk about some cases that I see, and we'll do a little interactive and just have some fun. Let me see if I can share my screen. This is so advanced for me. Can you guys see that? How do I make it more like a slideshow? Can I do that? And then you guys can still see me? Let's see. That's the ticket. Everybody see what I'm seeing, the first slide? Excellent, thumbs up. All right, so this is a little bit about the road to pediatric otolaryngology. It's going to be a little bit about being a woman in medicine, a woman in surgery, and a woman in pediatric otolaryngology, which is certainly less of a unique issue these days, although it is still, we are still somewhat in the minority. So how does one get there? I know you've had other talks about medical specialties over these weeks and months, but just to remind you that typically it's 4 years of college and 4 years of medical school. There are still some combined programs that you can do a 6-year program in some schools that will combine undergraduate and medical school, and there are even some 7-year programs. Within medical school, you can do just the straight MD, or you can get an MD PhD, which can be anywhere from 6 to 8 years total. There's some MD MBA programs and MD MPH programs. So you can get a master's of business, you can get a master's in public health at the time of medical school, but the vast majority, I'd say over 90%, are still doing just the 4 years of medical school and 4 years of college. Then there's residency, and down the line when you're thinking about specialties, I really, really encourage you not to focus on how long residency is. You have a long life, hopefully, ahead of you. At your age at that point, but it's really as residency progresses, the years get better and better, and you have a life outside of the hospital. So don't choose a specialty purely based on the number of years. Most ENT residencies or otolaryngology residencies are 1 year of general surgery. Our residency has actually, it's one of the first, we've gone to 6 months of general surgery. So it's unprecedented. We have you actually start ENT residency in your internship year. So it's mostly otolaryngology, and then an additional 4 years, and every program is going to require 4 years of ear, nose, and throat residency. About 50 to 70% of residents go on to do a fellowship, and that's just meaning more and more subspecialization. So within our specialty, you can specialize in pediatrics, which is what I did, laryngology, which is voice disorders, rhinology, which is sinus disorders, head and neck cancer, which is throat cancer, otology, which is just ears. So there, and facial plastic surgery. So there are multiple ways you can go if you have a special interest in one niche area of otolaryngology, even though that seems really specialized enough, if you so choose. And then after that is what real life is about. So, down the line, when you're thinking about what you want to do, if you want to be in medicine, look at the people who are done with their training at different stages. So they've been out either 5 years, 10 years, 15 years, 20 years, 20 plus years. And that gives you a sense of how happy people are with their choices and down the line. So why would one choose this crazy specialty? So it's a little bit of everything. You have to love being in the operating room. If you don't, this is not the field for you. You also have to love seeing patients, because our specialty is about 50-50 or 40-60, depending, of seeing patients in the office. So if you're not someone who enjoys that, this is not the specialty for you. If you do like interacting with people, and not everybody does, which is fine, this is not a specialty for you. But if you enjoy it, it's a good specialty, because it really is a nice balance of both. You have to be really interested in the anatomy. It's kind of complex anatomy. The head and neck anatomy is a bit of a challenge for those of you who've looked into it, even as undergrads or even before that. It's fascinating, but it is a little bit of challenge. You also have to like sort of the techniques and technology that we use. We have a lot of technology in our field, lasers and scopes and robots and things like that. So that's a really fun part of it, but that has to be something that you would enjoy. And even though it seems like a really narrow specialty, there's a huge variety of patients and a huge variety of diseases that we see. So what is it? So it is a surgical field. So you are considered, there is no medical ENT or surgical ENT. Every ENT is a surgeon by training, but it does have a lot of medicine in it, which makes it interesting. There's a mix of short-term and long-term care of patients. So for instance, I have plenty of patients where I've seen once, I'll maybe do one surgery on them and then maybe never see them again. So there's a very short term, and then there are patients that I literally see on the day that they're born, and I see them until they outgrow my practice, which is until they're 21. So there's a range of that, from seeing patients briefly versus seeing patients for their entire childhood. What's one of the things that I love most about my specialty is that we work with other specialties quite closely. So we work with radiologists, plastic surgeons, dermatologists, neurosurgeons, pediatrics, and for the most part, we work with anesthesia. So our closest colleagues are pediatric anesthesiologists. We share the airway. We work very closely on very sick children together. So it's a really nice combination of the two specialties. And you have to like new toys, because we always have new toys coming out, new technology, new scopes, new lasers, and that's a lot of fun. If you like video games, it is really what they say. There is some video game playing, in what we do. So just briefly about women in medicine, because I think this is really important, just to give you some perspective. So I'm actually finishing a book called The Doctor's Blackwell. We do have a Dr. Blackwell on our faculty. I don't know if he's related to the first female doctor in this country, who was Elizabeth Blackwell. And interestingly, her sister, Emily Blackwell, who doesn't really get as much press, was a surgeon. a couple of years after Elizabeth Blackwell. So that was back in 1849, which is a long time ago. It seems like a long time ago, but it took a really long time for women to be accepted in medicine. And so this was back in the time, we've all heard of Florence Nightingale, one of the first nurses. And that was even considered a little bit radical to have a woman doing nursing. And she was friends with Emily Blackwell and Elizabeth Blackwell, and it was about the same time, the mid to late 1800s. So about 50 years later, about 10% of physicians were women. In 1915, AMWA, which is the American Medical Women's Association, began. Around World War II is when Harvard Medical School began accepting women. Sorry about that, because most of the men were out fighting the war. Title IX, probably many of you have heard of that. It's related to sports primarily, and it's just to give you a perspective of women's equality in education. In the 1970s is when Title IX facilitated that women can get sports scholarships as well as men. So that was in my lifetime, so not too long ago. By 2002, so we're already in the new millennium, still only a quarter of physicians were women. But by a year or so later, almost half of the medical school applicants were women. And now anywhere between 50 and 60% of medical school classes are female. This hashtag, I look like a surgeon, was a social media sort of blitz soon after Me Too in 2017, just to sort of identify women, that there's no certain look to being a surgeon. And now almost half of surgery residents are women. So it has, in the last, what is this, close to 200 years already, women have come a bit of a ways in medicine, but it's been a slow way. So again, about 50% of medical school graduates are women. Before 2017, only about not even a quarter of surgical training programs were training women. When I was a resident, applying for residency, 10% of ENT residents were women. So, it has tripled, or even more so since then. Our residency program is about 50-50 right now. And then there's always going to be a lag because faculty obviously takes another decade or so. So about a third of surgical faculty are women. People often wonder, okay, great, you're there. Is that really what you wanted to do? Are you happy? So are we happy that we became surgeons, all women out there? Why? And so there have been some surveys that have been published questioning why we became surgeons. We like it because it's a hands-on specialty. We like the challenge. We like the immediate results. What would be a reason not to be a surgeon? So there are a lot of reasons not to be a surgeon. Residency lifestyle, and I really, really recommend not focusing on that. Residency lifestyle is better than it used to be. It gets better every year. People have finally recognized the importance of a balanced lifestyle and a balanced life in your mid to late 20s and early 30s. So that has improved dramatically. So I really, really discourage using that as a reason that you would choose or not choose a specialty. Practice lifestyle is another thing, because that is, your life is going to be different whether you choose one specialty or another. And again, length of training is something that I discourage you focus too much on, because there's really nothing you can't do. Certainly as your training progresses, as far as having a life outside of medicine. So, but practice lifestyle is definitely something to consider. Certain practices and certain specialties, if you're not a morning person, frankly, I'm not a morning person, but I did choose a surgical specialty, go figure. But, it's tough. You have to get up early. I mean, you cannot get around that. So there's certain things that, if you have to like that adrenaline, the rush of going in for an emergency. There are not a lot of dermatologic emergencies. And, there are not a lot of pathology emergencies. So if you don't like the idea of ever going into the hospital for any sort of emergency, you want to consider that when you choose a specialty. So some of the negative impacts, and this was obviously an older study, but it, not much changes. Things move very slowly. There is still sex discrimination. Again, residency lifestyle is a concern. Most programs, I think all programs actually have maternity leave plans built into their training. So that is something, people are having 1, 2, 3 babies during residency. So there's no restriction that way. But there's still some concern as far as the stress of going back to work. If you're considering starting a family, we have paternity leave as well. So it's not just that the female residents get time off if they have a baby. Although I will tell you, having a baby is certainly no vacation. But if it's male resident and they have a child, they get time off as well to help with the child. So there's a perception of a surgical personality that sort of goes around within the medical world, sort of a tougher, more abrupt, more brusque personality. And, I don't know, maybe that's true to some degree. Again, I think that's less so these days. There is still the perception of the old boys club. And I think that involves certain subspecialties within surgery. So orthopedics still has extremely low female numbers, on the order of 6%. So, there are certain subspecialties or specialties within surgery that tend to be, much more male oriented than female. But again, that's continuing to change. So I don't think that should be a detriment in either direction. So some of the positive impacts, I think once you get out into medical school and you start spending time, or even before that as undergrads, or even in high school, we used to have high school kids before the pandemic come and spend time with all the pediatric specialties at UCLA. If you have a positive experience, you usually connect to that person, whether it's a male or female, and if they seem like they have a happy lifestyle and a happy professional life, you may be more inclined to look towards something that they're doing. A lot of that is perception, but that's fine because usually perception is pretty accurate. If you perceive that they seem happy, you're more likely to look into what they're doing. If you perceive that they're unhappy, even if they're not unhappy, you're more likely to gear away. Or if you don't like that person, or if you don't, you find them kind of obnoxious, you may think that it's the specialty, not necessarily the person. So men and women are equally satisfied, but for different reasons. And again, this was an older study. The men, when questioned, talked more about training and compensation. The women tend to be more geared. And I think this is in any sort of field where a group is in the minority, they will tend to bond together. So there are a lot of women's support groups within surgical specialties. So I mentioned AMWA, the American Medical Women's Association. There's Women in Otolaryngology. There are all these women in surgery groups. UCLA has a women in surgery interest group sort of to support medical students female medical students who are considering surgery. So there tends to be extra support for better or worse, which the goal is obviously to pull more women in to the field. This, I think it was an interesting question, asking men if they thought surgery was a good field for women. 4.8 out of 7 said it was good. But if you ask women the same question, 6 out of 7 would say that it was good. The key is role modeling. So, in anything that you do at any level of your education, finding mentorship at any level is really critical because it does help you sort of look into your future, whether it's 2 years into your future or 20 years into your future, to get a sense of what direction you would like to pursue. So what's important, and this goes for everybody, level of work and life balance. It's kind of a funny phrase because I think work and life are the same. It's not like you have your work and then you have your life. Work is part of your life. I think just in general to have balance in your life is really important, and to just keep that in mind. Predictable time, and that's really, really something that some of you may have some experience with if you're later in your college years. But not having predictable time is a very uncomfortable feeling that unfortunately we get used to. Especially when you're a resident or you're, an on-call person, you don't always know, the idea of like, oh, let's do lunch. As physicians, we don't really have that as part of our day. We eat when our patients are when we have a break, but we can't necessarily, set a clock. So unless you're a psychiatrist where you have very set times for seeing patients, our time is very unpredictable. So, if you like control of your time, you want to consider that when you're choosing a specialty, because a lot of surgical specialties and anything in medicine tends to have sort of open-ended times. We don't always have an exact start and exact finish to our day. There is always time for relationships, friendships, other sorts of relationships, family. So it's really important to keep that in mind and not get too, narrowed in. And again, that goes through, for high school, college, after college, just in life, you want to make sure you maintain relationships. I know with pandemic, it's been a disaster, but when I'm not saying if, but when we get back to normal life, that's really important. And social supports and networks. I think that now there's a lot that's built into hospitals and colleges and high schools, but sometimes it requires individuals sort of seeking out some support outside of their work or their school. So just briefly, women in otolaryngology. So again, this is, I mentioned this, it used to be about 8 or 10%. Then it went up to 15, 20. Now it's closer, I have that it's, 35% of residents and fellows are women. Now it's closer to 50%. So I think that will continue to stay at about 40 to 50%, which is good. I mean, it's a great specialty. It's not necessarily a male specialty or a female specialty. No specialty really is. But, I think that women have been very successful and men have been very successful. It's a very nice camaraderie. It's a very sort of friendly specialty. So it's nice that that's sort of become more equalized. So breaking through the glass ceiling. So we talk a lot about leadership. I don't know if you've talked about that with other people, but it's one thing to just be a part of the specialty. It's another thing to be a leader in your field. The AAO is our academy, so the American Academy of Otolaryngology, which usually I think it has about 10 or 15,000 members. So the first woman president was in 2004. The first woman surgical chief at Johns Hopkins, which is sort of the mecca of general surgery, was in 2005. The first chair of an otolaryngology department was in 2006. And, just looking, this next figure is about women publications. So are we academically productive? There's been very slow increase in that area. And as with anything, there's always going to be a lag. You can't just enter some field that you've never been in and expect it to just all of a sudden be 50-50. So that's coming up as well. So what's the problem? So in general, women aren't necessarily as satisfied as men in their specialties. That's life. And hopefully that will improve, and hopefully it has improved. But there is sometimes more pressure for home and family. I encourage everybody that if you're going to find a partner in your life, to find a supportive partner, whatever that means to you. And, and just to really keep that in mind. And I think that the people who are happiest in the work arena are happiest in their home life. So it is really important. I can't overestimate that. But women tend to have more responsibilities at home. That's not always the case, but in general, it has been the case. There's been a changing culture of surgery. There is definitely not one way to be a surgeon or a doctor. You can work once a week. You can work 7 days a week. You can work anywhere in between. So there is no right or wrong when it comes to it. I think that you just have to understand, there's a push-pull that if you're going to be working less, you're going to not necessarily be a leader in your field, but that's fine. You may have a happy home life. If you're going to be working more, you're going to be at home less. So, you have to sort of find what, the sweet spot for you. I will tell you, after having done this for a while, Nothing is perfect, and you will have, there's no perfect balance, and you will have good days and bad days, and days that you feel like you've done everything right, and days that you feel like you can do nothing right. And that's, that's life. What can I tell you? But you can do it. It's an evolving field. It's a great field. Residency work hours, not to be, that we walked uphill both ways in the snow, but we did. And life is better now for residents, as it should be. They have a life outside of work. I know that. They work very hard when they're there, but they are not there 24/7 every day. So, I think they do have a happier work mentality than was the case in the past. In general, flexible schedules are much more common now. And, if you're somebody who likes to be busy, you will be busy. If you're somebody who prefers not to be so busy, you will not be so busy. It is really, as you get older, you sort of get to decide what works best for you. I frankly like surgical personalities. I think, we sort of have the concept of fix the problem, a little more direct about it. But I think it's a pretty nice way to be. Okay, so I'm going to talk about a couple of cases here. So if anyone wants to chime in or ask questions. So this is a child I saw in my office who was not in any distress or discomfort. And this is something that I see every day when I see patients. So if anyone wants to unmute and tell me what they see.
Swollen lymph nodes.
What's that?
Swollen lymph nodes.
Close. What are those big things in the back that I'm seeing here? What are these right here? So this is a mouth.
Tonsils.
Here's her teeth, her tongue. What are these right here?
Tonsils.
Those are tonsils, right? So these are tonsils, which are lymph nodes. So the tonsils are lymph node tissue, but they're a very specific type of lymph nodes that you can see. And you can see here that these tonsils are so big that we're not even seeing her airway. You can see, I don't know if you can see hopefully you can see my arrow. There's a little slit there where she can breathe. You know, the little punching bag in the back of your throat, the uvula, these tonsils are so big that they're blocking her uvula. So it looks like she would, not be able to be breathing at all. But she came in just because she had sleep apnea. She had snoring, noisy breathing, difficulty sleeping, some difficulty eating because these big blobs were sitting in the back of her throat. And so for this child, we would recommend removing her tonsils, which is what we did, but not an emergency. This is just something that we would see in the office. We grade tonsils. So normal tonsils where you can barely see them would be a 1. And then when they're all the way to when they're touching in the center, this would be a 4. So the maximum 4+ tonsils. So that's one of the most common things that you see as an ENT doctor, and certainly as a pediatric ENT doctor. Okay, so this is just to show you a setup for what we do in the operating room. So you can see here, this is a child. At the time, I think he was about 6, and he's undergoing a procedure called a laryngoscopy and bronchoscopy, and this is where the toys come in. He's completely asleep. He's under general anesthesia, but he does not have, you've probably heard about ventilators and intubation, certainly with COVID and people on ventilators. He is not intubated. He's breathing on his own. So there's no breathing tube in his throat. This is just a light where we can look down into his voice box and his trachea. And then this tube here coming off the side. Can you guys see my arrow? Just send me a thumbs up if you can. Yeah, thanks. So this tube here is actually a breathing tube, but it's not going down into his throat. This is just giving him a little bit of oxygen and a little bit of anesthesia. And then we have this other contraption here that it's called a suspension bar, and it's exactly what you think. It suspends this instrument here, which is a laryngoscope, up here so that you can work with two hands. So you're not holding the laryngoscope with one hand and then operating. You can actually operate. And this is where the sort of, video games come in, because you have two instruments going down there, and then we're actually looking at a screen when we're working. We're not looking down into that tiny little hole there. And I'll show you what the screens look like in a sec. So this is what we see. I hope you guys are okay seeing this. These are vocal cords, and we'll talk a little bit about what's on these vocal cords, but you can see here, it's sort of this triangular shape, and this is not a normal looking vocal cord. I'll show you a normal one in a little bit, but this is a child's airway. You can see they have these little dots here. We'll talk about that in a little bit. So these are abnormal, but this is what we see down that little laryngoscope. We have a little telescope that goes down that we can see down, and then this is down into the trachea. So this is a normal looking trachea. The windpipe here, you can see this is what's called the tracheal ring, and it's made out of cartilage. And it should look like a horseshoe, which this does. And then the back part here should not be cartilage, because what is right behind this soft stuff here, if this is the back of the trachea, what's right behind it?
Your esophagus?
Your esophagus, right. So they share what's called the party wall. So the front of the esophagus is the back of the trachea. So oftentimes breathing problems and swallowing problems, you can see how closely they would go together. If you have a problem with your esophagus, it can push into your airway. So they do kind of go hand in hand. Okay, so you saw this open airway here, and then you get to something like this. This is another child. So we took a look with that laryngoscope, just like you saw, and we saw this. So that's not very normal. So this is completely obstructing this child's airway. This was an infant. So the last patient was like a 7-year-old. This is a, maybe 6 or 8 month old. And you can see that this baby had huge mass blocking the airway. So this is the area where if you don't like your adrenaline to kind of shoot up and your heart rate to shoot up, this is not the field for you, because we do see some acute airway obstruction where the child is not being able to breathe. This was soft, so we were able to get the telescope past there to see the trachea, which looks sort of normal here, less normal here. So this does not quite look like a horseshoe. I mean, maybe a sideways horseshoe, but you can see here there's some collapse. So you can see the cartilage is kind of compressed a little bit. So this baby had two things going on. This was a little cyst that we just popped. And we took a little tiny endoscopic scissors, stuck it down the laryngoscope and popped it. And once we popped it, we were able to see, this is the epiglottis here, which is normal. We did put a breathing tube in. So this is when you've seen all these images on TV of people on ventilators with a breathing tube down their throat. This is a breathing tube. That's what it looks like, through the vocal cords into the trachea. And we opened up the cyst and put the breathing tube in. This is just it looks terrible. This is a ton, like literally like 4 drops of blood, but when you have it on the screen, it looks really gruesome. And then this was her trachea here, and it turned out she also had a heart problem that was pushing. So this part here is actually the heart pushing on the trachea with each heartbeat. So she had a heart surgery after that. But we opened up that cyst and she did fine. But this was a time where we didn't know what we were going to see. She came in with a little bit of, sorry about that, a little bit of noisy breathing. But then when we looked, we saw that she had this complete obstruction. As well as this issue going on. We were able to take care of the cyst at the time. And then later on, she had the heart surgery to take the pressure off of her trachea. Another example. So this is a child who had, she was about 8 years old, and she had a seizure at home, which was the first time she had a seizure, and she stopped breathing. So her parents called the paramedics. And they put a breathing tube in because she had a respiratory arrest. And at the time of the breathing, and they left the breathing tube in for a few days, took it out, she went home and everything was okay. Her seizures were put under control. But then she developed this cough that kept coming and going. And she came to see us with this cough. And it turned out she had a little sort of scratch from where they put the breathing tube in, and she developed this huge mass here, and you can see she would cough and it would come out of her airway, and then she would breathe in and it would go down. These are her vocal cords, which look completely normal. She was able to breathe a little bit around this space, but it was what's called a ball valve effect. So this was kind of flopping in and out of her voice box for about 6 months. And we took it out in the operating room. Again, this looks like a bloody mess.
Is your computer gonna die?
What's that?
Oh, I'm so sorry.
That's okay. So anyway, so took it out and she did fine. But one of the fun things about our specialty is we don't always know what we're going to see when we have a child with symptoms, certainly if it's urgent. So we sort of have to be prepared for anything. And hoping we can take care of whatever we see. But again, and oftentimes we don't necessarily know what we're going to find. So I'm going to talk a little bit about stridor, because that's one of the most common things we see as an urgent issue is noisy breathing. So stridor, which is something that is very common in pediatric ENT, is an inspiratory, so you breathe in, or an expiratory noise. And it has a musical quality to it. So it has a pitch. So as opposed to snoring, which you probably all heard, has that kind of rough, grumbly sound, or stuffy nose that has a certain sound to it. Stridor has sort of a musical quality to it. And it's somewhere, as opposed to wheezing, which is what you would hear with asthma, it's somewhere in the trachea or above. You're going to hear that noise. So it's high pitched and it's due to some sort of blockage in the airway. And so the question is always, where is it coming from? Is it coming from the voice box? Is it coming from right above the vocal cords? Is it coming from the trachea itself? Some people, babies that we see, have stridor all the time, what we call chronic stridor. They're not necessarily in any distress. But sometimes when there's more of an urgent issue, they will have sudden onset stridor where it'll occur quite acutely and needs to be treated quickly because it's obviously something new going on. Babies especially, they may be in any sort of distress, or they may not be in any distress. Desaturation, which is where their oxygen level goes down. Again, we've been hearing a lot about low oxygen during the pandemic. So normal oxygen is 90 oxygenation, which means how much oxygen percent is in your blood should be 95% or above. Once it turns 85% or below, that's when the lips start to turn blue. So, we call that cyanosis. So anytime a baby has blue lips, we know that their oxygen is below 85%, which is certainly not normal. So what do we do when we assess somebody with stridor? First of all, it depends on their age. So a newborn with stridor can have something what's called congenital. So it could be something that they were born with. Onset, did it come on suddenly, or is this something that they've had for a long time? We try to assess where the location is just by their history and exam. And again, the quality, is it when they breathe in? Is it when they breathe out? Biphasic means that it's when they breathe in and when they breathe out. Does it have a high pitch to it? Does it have sort of a staccato for the musicians out there? That's sort of that broken pitch sound that we hear. Does it come and go, or is this something that they have all the time? So as with any specialty, you want to get a really good history from your patient as far as what's been going on and how long it's been going on. So we look at the patient. So I see lots of babies with stridor, and some of them are what are called happy stridor babies. So they just sit there and they're and they have this really noisy breathing, but they're eating and they're playful and they're happy. They're not in any distress. So those are less worrisome than the babies who look like they're really struggling and uncomfortable. Cyanotic, I mentioned. So if they're looking blue, I always ask the parents if they've had any blue spells at home where they've turned blue even briefly. Do they seem playful? Are they growing? So all those sort of basics that we want to see when we're seeing a baby with noisy breathing. We also want to see if they're using extra muscles to breathe. So, sometimes if you sprint across the field or, do some sort of sport, and you're sort of using your extra muscles to breathe, that is a sign of distress. So you always want to look for that, in a child, if they're having any extra muscles that they're using to breathe, that it's usually a sign that they're working too hard. So we're going to talk about a case. It's a little bit tricky, but we'll see where it goes. So this was a patient that I saw, MZ, we'll call him, and it was a 4-year-old who had a history of asthma, and he came to our emergency room with wheezing. He was given nebulizers, so steroids through the nebulizer. He was also given a shot of steroids, as well as a nebulizer with what's called a bronchodilator to try to open him up. And he didn't get better. Actually, he got worse, and he became acutely stridorous. He had a chest x-ray, which was normal. He had a consultation with a pulmonologist, and they didn't find anything abnormal with his lungs. And then they consulted us, and our resident did what's called a fiber optic laryngoscopy, which is a little flexible scope that goes in the back of the nose, and actually it has a turn to it, so you can look straight down and see the voice box. You can't see the trachea, but you can see the voice box. So based on what they saw, we took the patient to the operating room urgently. Does anybody have any ideas of why this would have been? So he had asthma, he was 4 years old, he was having some wheezing, and then all of a sudden he became in much more distress. Does anybody want to chime in what they think could be going on? Don't all, okay. So this is the same patient that I showed you. This is one of his probably greater than 50, 60 surgeries that he had with me over his childhood. He is now, I think, close to 30, about 25. So this is him. This is those vocal cords that I saw. And this is not from that emergency visit, because during his emergency visit, I was not taking pictures. But what he has here, if you can see in this photo here, so you saw those white vocal cords in the other patient, these little tiny dots here, each little dot is what's called a papilloma. So he had papillomas or warts of his vocal cords. Which is and it usually just involves the vocal cords themselves, and it can fill the airway. So when he first came in, he had an airway filled with vocal cords. So in fact, he did not have asthma. He just had papillomas. His trachea was normal. His lungs were normal. So this is a rare disorder called RRP, or recurrent respiratory papillomatosis, but it is the most common benign lesion of the larynx in children. We see anywhere from 2,000 to 3,000 new cases per year in this country. Typically, kids present with hoarseness, which is very common in kids. If you know any young kids who scream a lot, anywhere between ages 4 and 10, they often have a little hoarseness. But if this is chronic hoarseness that progresses to any respiratory difficulty, stridor, or cough, they need to be evaluated, hopefully sooner rather than later. It can sound like asthma because it also has kind of a wheezing quality and coughing, and average takes 6 to 18 months to diagnose these, because oftentimes, again, they'll mimic just hoarseness or asthma or a little bit of wheezing and coughing, which is very common in kids, when actually it is these lesions that are growing. So what is this? Very important. It's caused by HPV. It's the same HPV that most of you have heard about. It's human papillomavirus, and it is it's maternally transferred. So during pregnancy, through the amniotic fluid, through the placenta, if the mother is carrying HPV, it could be transmitted to the child. They don't usually present at birth with these lesions, but usually sometime in the first 2 months to 3 years of life, typically toddlers when they present. They fill the larynx, so it can cause complete airway obstruction. It rarely involves the rest of the airway, but it can go down into the trachea. It is caused by HPV 6 and 11. There is no cure. So once a child has recurrent respiratory papillomatosis, it is for life. Oftentimes it will fade out as they get to be about 18 or 20, but oftentimes this could be a disorder for life. There are multiple therapies once this is developed, but there's no formal cure. Sometimes it just burn out and it goes away, but oftentimes this is a lifetime or certainly throughout the childhood. So the HPV vaccine will block the maternal transmission, because if the HPV vaccine is given before somebody is pregnant and you don't carry HPV, you're not going to transmit it to children. So the goal is eventually that this disorder will be eradicated. So this is another example of what it looks like. It looks like sort of, we call it like this shag carpet of lesions. So this child would be severely hoarse. They wouldn't have a normal voice. So those nice white vocal cords we saw in an older slide, that's what creates a nice clear voice. This kind of voice sounds almost like a really, really rough, gravelly sort of frog sound to the voice. It's very tricky to treat these, because if you remove them, you're going to get scar tissue, and then you'll have other problems from the scar itself. So these issues are quite challenging. What are the treatments? So we bring these kids to the operating room. You can't treat them in the office. Adults who have this, and some adults do have RRP, are treated in the office, but normally it needs to be treated under general anesthesia. They undergo this laryngoscopy where you saw the photo, and a bronchoscopy. We use a laser to remove the lesions. Back to toys, we also use something called a microdebrider, which is like a little tiny kind of like a roto-rooter vacuum cleaner that fits down into the larynx. You can picture a tiny little stick there. Medical therapies have been very successful. A drug called cidofovir, which is an antiviral, used initially to treat eye infections in patients with HIV, is now used for this disorder. So for those of you who have done, I guess, biochemistry, it's a cytosine analog, and so it blocks DNA synthesis, and this is a DNA virus. Again, it was used as an antiviral for CMV infections. RRP was treated with cidofovir first in 1995, and now it's used quite routinely. It's continued to be off-label, so you've probably all heard the term EUA, or Emergency Use Authorization. This is still under EUA, even close to 30 years after it was being used. It is not FDA approved for this use. And we inject it directly into the voice box, so it's not something as a pill or an IV or a liquid medication. It's given directly to the lesions themselves. So this is an example. These are nice, clean vocal cords. So this is a patient who's had papillomas. Now they're clear, their disease is clear, but because there's still virus in the area, we bring them back, a couple times a year and give them injections to prevent the virus from growing. And you can see this is a tiny little needle going directly into the vocal cord, and we would bring, obviously under general anesthesia, bring this child to the operating room to inject their vocal cords to prevent regrowth of the virus. So this is a normal looking airway here. Here are the vocal cords. This is down into the trachea. This is what's called the epiglottis, which closes off your airway when you swallow, so food doesn't go down the wrong pipe. This back here, this little tiny line, this goes down into the esophagus. So you can see how close the voice box is to the esophagus. After we do the injection, we sort of push on the vocal cords a little bit so they don't get too swollen, because obviously we're injecting some fluid into there, so it's going to close off the airway. So this is literally a tiny little spatula that we use to sort of open up the airway after the injection. So this is what I always tell, and I give this talk oftentimes, the Strider talk, not the other part, to pediatricians, and also to trainees in otolaryngology. Pediatric Strider, which is one of the most common things we see as urgent issues in our specialty. So the take home is always, common things happen commonly. RRP is rare, but don't exclude the rare stuff, because certainly at a place like UCLA, we see everything. always think basic. So think of the really most common things, but then expand, what else could it be? What else, what else, what else? And when in doubt, go with your gut, because it could be something else. And this is just in general, in medicine, one of the things that we learned very early in our training is, and it sounds so basic, but it's so important, is to identify a sick person. And by that, what that means is you go to sleep that night not worried about this person. If you're going to lose sleep over this person's illness, then there's something going on, even if you don't know what it is. And that's really important in medicine, is that you don't have to necessarily know the answer, but you have to know that something's not right. And you have plenty of other people who can help you figure that out. But if there's something wrong, never worry alone, and go with your gut, and that will usually be the right way to go. So you can make it work in anything that you choose. I think my specialty is great. Hopefully everyone else you've spoken to has said the same about their specialty. The possibilities are endless. If you're going into medicine, there is not one way to do it. There are a million ways to do it. If you're interested in just seeing patients and being very clinically oriented, that's something you can do. If you prefer doing research, and you may not know that at this point, but as you sort of traverse your education, you might find that you love working in research. That's a way to go. You can certainly combine them in any way, whether you want to do 50-50 or 40-60. There's no one way to do it. Or do you want to do something else? Are there other things that you can do? And the nice thing about medicine now, it has really become a much more sort of there's more depth and breadth, I would say, to medicine. So plenty of physicians choose to go into administration and healthcare administration, whether that's within a hospital or within a health system or within a public health system. Their business endeavors, and there used to be this sort of big divide between you're a business person or you're a medicine person. Most physicians have no background in business and no background in finance, but now it's become more combined. And so there are physicians who like to pursue business aspects of medicine, public health, global health. I know plenty of physicians who travel the world, whether it's once a year for a week, or whether they go every month, or spend part of the year in another country, or spend a lot of time working in global health. That's certainly an area to consider. And then there's media and social media, and I don't know, you guys found me on social media, so I think that answers that. It is, become much more sort of mainstream, I guess, for physicians to be more vocal in social media, and, certainly to advocate for better public health or better messaging, because as you know, there's really no barrier, or nearly no barrier, in social media as far as medical misinformation. So I think physicians have really taken it upon themselves to give good information on social media. And writing, I enjoy writing. I began writing just little blogs and writing little pieces and op-eds and submitting pieces. And, that turned into sort of a larger area for me. I wrote a book a few years ago called Hype, which is not an ENT book. It's a general medical book about, as you can see, exaggerated claims and bad advice. I live and work in Los Angeles, so I had plenty of information and plenty of material, but it was something that I would never have considered doing when I first entered medicine. But it was, sort of a nice sort of side area to explore and learn, and sort of a different way of communicating than just one-on-one with patients. And I think the point of that is that you can really branch out in whatever, even if you're in a really narrow field, that medicine itself has so many different avenues where you can go. So, and this is just some happy operating room personnel. We all have a good time. Obviously, you can see it's pre-pandemic because they're not wearing masks. These are not N95s, but not much has changed. We're working on doing it. This is an instrument that I use. Actually, it's called a coblator. It's a radio frequency wand that we use to remove tonsils. So it's a lot of fun. So I think we're good. And this is, you can do it. Isn't that cute? That's my kid. She's now has her driver's license. So I am happy to take any questions or comments or concerns. Can open it up.
I have a question.
Sure.
What was your favorite part of being a med student and a resident in the field?
So med school was a lot of fun. I would say the first 2 years of medical school were pretty much like an extension of college. So, a lot of classroom work. We did, labs, and we did small groups, and we had lectures. We did a little bit of work, seeing what it was like to be a doctor. So the first 2 years of medical school were fun because it was hard, but it was just like college in a way, but just much more concentrated. What I liked about medical school, later on, sort of in the clinical time, was really just getting to see all the different specialties and sort of dipping your toe into different areas. And, I think most of us will say that that different specialties have different personalities, even though we try not to say that. But, it was fun to sort of see, what it was like to be a neurosurgeon 1 month as opposed to being a dermatologist 1 month or a radiologist. And then I think one of the fun parts is when it clicks and when all of a sudden you feel like, wow, this is it. And I think a lot of medical students get really frustrated because they don't know what they want to do. And they get a little bit nervous that, I don't know what I'm going to do. And I don't know if I'm going to figure it out. And the reality is that a lot of people change their minds. And I think that's something that is very uncomfortable for people who are very focused and on this road to being, I want to be this and I want to be that. I've been working so hard. But I think to understand the flexibility, but when it does click, then it does feel really good, and you have a really good, and you feel like you're kind of like stepping into this little club that's going to welcome you and support you along the way. So yeah, residency was fun too. I mean, I knew pretty early on that I wanted to do pediatric ENT. It wasn't something I considered during medical school, but I knew pretty early on in my residency. But the residency itself is not very geared toward pediatrics. So it was a lot of stuff that I wasn't necessarily going to do in my future, but it was, it was a lot of fun. It's a very, very tight-knit group, our field. It's a very, very small group. I felt very supported by my co-residents. We're still friends, after all these years, we're still in touch. So it was nice. I think our residents have a pretty good time with each other, it seems.
Great. Thank you so much.
Sure. Yeah.
There is a question in the chat. If you could just open that up.
Yeah. Have you ever corrected a deviated septum? Is that the question? I have. Why? Were one of you my patients? I hope not. Yeah, the septal surgery, which is straightening the cartilage in the part of the nose, in the front part of the nose that is a little bit curved. So one thing to say, if this is related to some personal experience, no septum is perfectly straight after the age of about 6 or 8. Everybody's septum grows as your nose grows, and because it's cartilage, there's going to be some buckling. So nobody has a stick straight perfect septum once they're past early childhood, even if you've never broken your nose. So straightening that is a fun procedure to do. It's not that commonly done in children, but certainly in teenagers or late teenagers, it is a pretty common surgery to do. There's septoplasty, and then there's septorhinoplasty, which is straightening anything on, the outer part of the nose, which, oftentimes is done under one procedure. I don't do rhinoplasties, but occasionally I'll do septoplasties, for teenagers, late teens. We try not to do it too early in teenage years unless there's severe obstruction, because the face is still growing, in late childhood and early teen years. Let's see. Besides academics, what are some things you can do to better your chances of getting into medical school? So I think that for medical school, they are more and more inclined to look for balance. And, I know that's kind of a soft word, but, I think that, what they're looking for are people who are leaders and have interest in other people. And there's so many different ways that that could be manifested. So, if you are, teaching little children how to read because they haven't been in school because of the pandemic, or if you are, traveling somewhere and, working with underserved people, or if you are, have other sorts of interests or talents or skills that require a lot of discipline, if you're a musician or if you're an athlete, I think, they recognize everything. They're not, I think, people get really, really focused on academics, and it's certainly critical. But that's sort of the base. They don't really, if you're, have a certain grade level and certain, what is it, MCATs, I guess they still, are they still doing the MCATs? That, if you sort of reach a bare point, that's sort of everybody, and then they get into the details. So, I think, something personal that you've experienced, they do read the essays. So I think that's really important, just like they did when you apply to college, or if you're applying to college, the essays are really important, and, who you are as a person, because it's not just, it doesn't matter how well you did in biochemistry if you're not going to be a nice doctor, I think. Any other questions?
Hi, I had a question, Dr.
Sure.
Shapiro.
Yeah.
So have you ever treated pediatric patients with SSCD? Because like right now, I'm a research associate under Dr. Gopin. I don't know if you know Dr. Gopin. Yeah. So I'm like researching like a project right now. So like I really want to hear like more of what's like treating the patient than like performing like retrospective studies I'm doing right now.
We don't see, we don't see kids with that. That's primarily, yeah, I mean, maybe teenagers. I haven't seen any kids with it though. So that's great. Yeah, I'll tell them I saw you. But yeah, I bet by the fall you will, if you're still, what year are you in now in school? Yeah. Okay, so you have time. Yeah, hopefully in the fall you'll be able to get back.
Thank you.
Sure.
I had a question.
Yeah.
So, how's it like when you're working with children specifically? Because in a lot of retrospect aspects, a lot of people think that working with children has a lot of capabilities versus if you're working with adults, it's like the mental capabilities, if that makes sense. So, like, what advice can you give if you want to work in a field specifically with children?
Kids are the best. I mean, I really enjoy working with them. I mean, there's some challenges that you don't have with adults. Like for instance, a lot of what I do, they don't like to have their ears looked at. They don't like to, have their nose. So, there's a little bit of, crying, and they get upset and they kick and things like that. But for the most part, they're a lot of fun. They're very honest. They are inquisitive. And what I like to sort of find in kids, what I enjoy about it is that, to sort of find what interests them or what they're worried about. Kids have a lot of fears. So do adults, but kids can actually verbalize them a lot better and a lot more sort of realistically than adults can. And it's a lot of fun to sort of address them and allay their fears, as opposed to just, oh, just hold still, it's no big deal. Certainly going into surgery is always interesting with children. And there's certain age, sort of every age has its worry. So for instance, young teenagers, if they're going to have anesthesia, they usually worry about two things. They worry about waking up in the middle of surgery and not waking up at all. It's almost always what they're worried about, and needles. So if I can sort of work through all of those three things, with them step by step, as opposed to I'm nervous and I'll just say, don't worry, it's going to be fine. That's not really helpful at all. But just sort of address the concern about waking up in the middle of surgery, address the concern about not waking up after surgery, and address the concern of needle phobia or needle worry. We can get through it. So I think, kids are their own, kids are not just small adults. We always say that. It's a lot of fun. I think, it's different to be, what the kind of work I do as opposed to a pediatrician, where, they really have a closer relationship with each child. They see them quite frequently. They know them for their entire childhood. They know the family. They usually know all the siblings. For instance, I take care of children, but I don't necessarily take care of the whole family, if it's just one child who has an ENT problem. So it's great. I mean, I'm not sure what was exactly what was the question? I kind of went off on children, but.
I mean, I was just wondering, because what kind of characteristics or traits do you need when you're working with children? Because a lot of times people say you need to have a lot of patience, a lot of diligence, or just in general when you're working in a specific specialty. I was just wondering.
Oh, like what is it like to be a pediatric person as opposed to an adult person? Yeah.
Mm-hmm.
Like sort of this, again, that's like a stereotype, like, oh, like I always say, like, just because I take care of children doesn't make me nice. But you have to be nice. You have to, you have to enjoy them. You do have to have a certain level of patience and tolerance and flexibility. But again, I think that, and it's different because I do surgery. They're also asleep at the same time, within my field. So, taking care of a child under anesthesia is different from taking care of an adult under anesthesia. I don't know if there's necessarily a type of person. I think certainly pediatricians tend to have a certain style about them, I would say, and probably within surgical specialties too. You have to love it. Otherwise, don't do it. Because, it's like I have an office and there are adults seeing patients down the hall and they hear the kids screaming. It has to not bother you, I guess. You have to sort of kind of roll with it. But you, again, it's like anything else. If you don't like it, it's not going to work for you. But I think, if you enjoy being with kids, if you enjoy being with parents, then it's great. Any other questions? Reading the chat. I'm reading the chat. Any other questions? No? Okay.
No? Okay. So
good.
Then thank you so much for coming again. I really enjoyed your talk. I actually learned so much today. And it was so nice meeting you, and your advice was amazing. So thank you again.
Oh, thank you. You guys are great, and good luck. And I guess you know how to find me. So if you have any other questions or if you ever want to ask me anything, I am around.
Thank you.
All right. Stay well. Have a good weekend, everyone.